So you've got different.
Can I ask you in regards to the photograph? So let's say that is a size 3 or size 4 tonsillar size.
4, I'd say, yeah.
So in regards to the function of the tonsils right now, when they're hypertrophic, what is their functionality? Are they hyperfunctioning? Are they hyperfunctioning? Are they doing the job that they need to do?
Okay, so you've got two issues there that we're conflating. You've got on one hand, you've got the. Sorry, Ken.
Sorry, could I trouble you to repeat the question for the virtual Zoom audience? Thank you.
In regards to this example where you have a type 3 or type 4 tonsillar size, my question is in regards to the function of the tonsil in a case like that. Is it helping or making worse what the function should be for this type of organ?
So I think that airway always will trump function. And so your airway has to take precedence because obviously that's what's keeping you alive. In terms of the function of the tonsils, I think that they're a good thing to have in the first year of life. But, you know, what can sometimes happen is that the size doesn't determine their functionality. Okay, the functionality is a product of your immune system, which is, you know, way beyond my intellectual pay grade to start talking about. But it's the functionality of those tonsils to make antibodies, process bugs, and have a good immunocompetency is completely different from the size. Would you agree, Narinder?
Yes. So without getting into the weeds of the physiology, the primary function. Sorry. Benefit of those on Zoom. So without getting too much into the weeds, of the essential function of the tonsils is immunological. So they're meant to where, you know, B cells produce antibody initial responses to infective agents. So the question was, you know, whether larger tonsils maybe have a more effective immune function, and the answer is that when they're actively inflamed in the process of infection, that may be the case. But the biggest problem we've got, as Perry has very eloquently not actually producing antibodies is of no benefit to anyone. And just to add to that, there is a whole ring of lymphoid tissue in that area. It's a common question we get from parents. Oh, aren't they going to get more infections? Aren't they going to get more colds if we remove the adenoids and the tonsils? You know, and it's an old wives' tale. You know, we've done millions of tonsillectomies and adenoidectomies around the world. We would see that if that was the case. And if we actually try and understand why that is the case, there's a ring of tissue in that area called Waldeyer's ring of lymphoid tissue. So just by removing the tonsils and adenoids, we're not depleting the immune function. It functions just as effectively. Sorry.
We're completely in sync. And in fact, Lorinda just said exactly what I was going to mention, which is Waldeyer's ring. There's this concentric ring of tissue, and you've got, even if you take your tonsils and adenoids out, you've still got patches of lymphoid tissue, at the back of the tongue and on the posterior pharyngeal wall. So we call them pharyngeal bands. And if you look at mouths, you'll often see these little patches of tissue scattered around the back of the throat. And often they will settle down when you take the tonsils out. And it's because all of these areas are in communication by the lymphatic circulation. And I'm going to talk a little bit about something related to that in just a moment. So yeah, we can grade the tonsils in terms of size. But what I also wanted to talk about was that it's not just how big they are, which is going to determine their problem, but it's also how big the size that they're in. But also, if we talk about the traditional indications for tonsillectomy, there have been these things put out that, you had to have 4 attacks in 3 years, and 3 attacks over 4 successive years, or 6 attacks in over a year. And my eyes just glaze over when I hear that, okay? Because that's assuming that every one of these attacks of tonsillitis are the same. But you can have N equals 1 episode where little Billy is a bit sick, he's a bit off colour, tonsils a little bit mucky, but he's a bit of a trooper and he goes to school, doesn't even go to the GP and get some antibiotics. And you've got another person who just about winds up in intensive care with airway obstruction, incipient peritonsillar abscess, almost needed to be intubated. And they're both N equals 1. One's hardly touched the sides, and the other person's almost died from it, their tonsillitis. So you can't really say that all of those are numerically equivalent. You can't, okay? So we can look at the traditional indications, which are the number of attacks and hypertrophy, but I think you want to be a little bit nuanced about your decision-making. And it's not just how big they are, okay? And it's not just how many episodes that they've had, but we want to also look at what I call the natural history. In other words, are these problems abating or are they continuing? Number one. Number two, what's the relative size of the oropharynx? And so the analogy I give people is it's furniture in the room versus the size of the apartment or the house. If you've got a double bed in a 1-bedroom unit with a dining room table there, you're not going to have much room to move around. But if you've got a king-size bed in a 25-square house, there's still plenty of room, okay? So if you've got big tonsils in a person who's retrogenic, retrognathic, tapered, compact maxilla, that's going to be far more clinically significant than just looking at size of tonsils and grading them. So I think, again, that's where I want you to be a bit more nuanced, is what is their functional reserve? And the other thing that we often overlook is what I call the chronic low-grade pharyngotonsillitis. So you get halitosis, lassitude, and you get these tonsillus. And that's basically concretions of food debris in the tonsils, which have this low-grade sort of septic phenomena. And not uncommonly, when I grab the tonsil to distract it, to start removing it, these bits of debris ooze out. And I love seeing that, because I almost know for certain that that kid is actually going to be a lot better clinically from both a obstructive perspective, but also this low-grade inflammatory state. So the tiredness may be due to the low-grade septic change in the tonsils, as well as the airway congestion from the hypertrophy. And this is obviously an intraoperative photo. And the bottom is the front teeth. Up there is the tongue being pushed away by the gag. And you can see here, there's almost no airway. And that is someone who's got everything splintered out with a gag. And that person actually had an AHI of 120. She was actually falling asleep in front of me during the consult, couldn't stay awake for more than 20 seconds before she nodded off, in a Filipino background lady. And she was completely fixed by an operation. So that was a sort of a life-changing thing for her. What do we do? You don't really need to know about this, but basically we can take them out in different ways, and it's not that relevant, but there's diathermy, there's coblation, there's various devices, and then there's a new form of a new approach. Narinder, have you done any tonsillotomies? Yeah.
Just a 5-minute warning, Barry. Just
Thank you, Ken. It's basically you basically shear off the tonsil, but leave a cuff so that you're not going into the muscle, and you can use these wands to do it. These coblation wands. This is what I do. Monopolar diathermy. I use a really low setting. I dissect out the tissues. I use an extracapsular technique. Try and do as minimal char as possible. I cover the area with some BIP gauze. You're all familiar with BIP, bismuth iodinated paraffin paste. It's got antiseptic and hemostatic quality to it. I apply some bupivacaine anesthetic topically and regional infiltration. I operate with professor of anesthesia in Royal Children's, who comes and does my private stuff. And we've got this nice little concoction that I think works really well. And we use paracetamol, we use celecoxib, which has an anti-inflammatory but not an antiplatelet effect. So I'm not worried about the bleeding issues associated with non-steroidals. We give them oxycodone liquid. And my post-operative regimen is that I get them to gargle with peroxide at least 4 times a day. They wash out their mouth with some water. They have some xylocaine viscous, numbs things nicely. I give them some Coca-Cola drinks, some lemonade slushies, some apple juice granitas. And if they're a cute little kid, I tell them to get some ice cream, some hundreds of thousands, some chocolate sprinkles. They pour some lemonade on it, and they've got this spider, and their eyes light up, you know.